there are still new participants who wait one more minute so everybody is able to join us. So welcome all of you. We have 32 participants I can see, and the section Functional Neurosurgery is happy to welcome you on this EANS webinar about directional lead for DBS. And today we will discuss two topics about a very interesting and actual survey among the EANS community about the directional leads. My colleague, Pedro Batista, neurosurgeon from Lisbon, will tell you something about the results. He's also one of the EANS function section panel member. And the second part of this webinar is about the most recent literature about directional leads. Marie Kruger is the presenter of this topic. Recently, she moved to the UK. She is also one of the board members of the functional section of the EANS. After the session, there's time left for questions. Please feel free to participate during the Q&A. We are really interested in your opinion and your experience about this kind of leads. This is also a good opportunity to ask the great experts in the field of DBS your questions. The questions can be asked in the Q&A. Please, Pedro, the floor is yours.
Thank you, Linda. Thank you all. I'll just share my screen. I hope everyone can see it. So welcome everyone. Like Linda said, I'm Pedro. I work in Lisbon. And I am part of also the authors who are prepare this survey, which we'll publish in some time, we hope. And it's about directionality and the impression of the community about directionality. And so we devised a survey about the use of this technology, and we sent it out to functional EANS functional section members and also ESSFN, and these are the results. So we made 50 questions, most of them multiple choice, but some open questions, and divided like 9 demographics and 9 general questions to characterize the respondents, and then 11 about the surgical strategies with directional leads, 13 about programming strategies with directional leads, and 8 about the future perspectives on the technologies that people think might be useful in DBS. And these are our respondents. We had a total of 50 respondents, but one was duplicate. So in the end, we analyzed 49 answers distributed between 16 countries. Most of them from Europe, only 2 answers outside of Europe, one from India and one from USA. 42 respondents were male, and most of the respondents were with the age between 30 and 50 years. The majority were neurosurgeons, 38, 8 neurologists, and also 3 specialist nurses in DBS. Most of the respondents were from university hospitals, only 7 from regional. And they had experiences, most of them between 5 years and 20 years with DBS, their personal experience. And their institutions were making an average of 15 to 50 with the majority, but there were some with more than 100, and 8 between 50 and 100 DBS per year. So first thing we asked was if they had experience with directional leads, and 89.8% of the respondents were currently implanting the leads, and most of them had between 2 and 5 years of experience. The companies that they worked with were mainly Boston, then followed by Medtronic, and finally Abbott. But most of the respondents preferred Boston, as we can see here. And then we were asking what indications were they doing in their institutions in general. And this followed the trends for DVS, right? Most of the indications were movement disorders, Parkinson's, tremor, dystonias, then followed by pain, OCD, and epilepsy. And then the less common indications, Gilles-Latourette syndrome, depression, very few schizophrenia and dementia. And then we compared it with what indications are you doing for DLEADs. And here we see some changes because most of the centers, the respondents said that they only do, they think that movement disorders are the best indications to implant DLEADs for Parkinson, tremor, dystonia, and all the other indications fell. So what were the reasons to implant a DLEAD? Most of the respondents said the leads were implanted for clinical or programming reasons, and only a minority for other reasons like anatomical or surgical reasons or for scientific reasons. And of note, it's also interesting to note that 2% of the respondents said they do it as a standard. So they only implant DLEADs now. Then we asked, what do you feel about DLEADs? Do you think they are an advantage or a disadvantage? And no respondent thought they were a disadvantage. 48% thought they were a major advantage and 52% a minor advantage. Then we went to analyze the surgical strategy and if something changes with the surgical strategy. First, we analyzed the planning and the implantation. And so we asked, do you change your planning with DLEADs? And 81% of the respondents said, no, we don't change our planning. Only 6 respondents do it. 1 does it always, and 5 on an individual basis. And what changes do they do? These 6 respondents gave these answers. And so most of the changes are in the Z-axis, no changes in the Y-axis, and 2 make changes in the X-axis. And 2 of these 5 respondents gave some details, and they say that they plan slightly deeper in order to leave a segmented contact on the target and not the most ventral one. And then we asked what are these adjustments made by nucleus? And they said, yes, they do it for the NSTN, they do it for the VIM, and almost all do it for the GPI, but not all. And then we asked if they accept a lower side effect threshold when doing intraoperative testing. And half of these 6 respondents said no. A third said, well, I accept it, but it's not intended. And only 1 said that a lower threshold for side effects is intended with directionality. What about the intended orientation? Do respondents try to orient the lead at some point during their implantation? And 70% of the respondents said yes, they try to do it. And the vast majority try to put the guide marker facing anteriorly. Then we moved on to trying to understand what is the community doing regarding the determination of the lead's final orientation. And we can see here that there is a wide variability, either on the method used to determine this final orientation and also on the timing to do so. You can see here that the most used methods are CT with algorithms or the intraoperative X-ray marker. But the timing is even more variable. 14% preferred, say that we can do it on the first 24 hours, 25 during the first week, and 26 after the first week because of the shift that happens. Then moving on to programming strategies. 31 of our respondents had experience programming DLEADs, and at 75% of the institutions, the neurologists were doing this programming. And in half of the institutions, neurosurgeons or DBS nurses were doing the programming. And you should note that in many of these the institutions, the programming was done by more than one of these, and in some by the three. And so what are the reasons to use steering? So these are the reasons, because it's not to implant the leads, but to use, to make a program that uses a segmented lead instead of omnidirectionality. And they said that they use the steering when they want to get away from side effects. 58% of our participants. And a bit more than a third says that they do it in order to improve the clinical outcome. And very, very few of the respondents claimed to use it to save battery. We also tried to understand how many of the patients are using directionality at each institution. And obviously, this is an educated guess because not everyone has these numbers. And we can see here that initially, after the implantation, a lot of centers have less than 25% of their patients on directionality using steering. But this percentage falls after 1 year. And more and more patients start using this steering, which is also what the literature points at. Then how much time do people take to program the leads? What is their impression? And most of the respondents, 63%, feels that they take longer with the leads. Only 7% feels that they are faster. And the reasons they give, well, these were three responses. And the reason they give is that they use the imaging software, and so they don't do any monopolar review. The second one says more or less the same. They use GuideXT. And the third respondent say that it was obvious. Well, that's the answer you gave. So we analyzed what programming methods are being used. And we can see that 75% of our respondents are using either a clinical trial and error or a directional review. And very few are mainly using imaging software or other imaging methods. Then if we ask specifically if they use visual or imaging information for the planning, this percentage increases. And so 64 says they do sometimes, not always. 7% never, and only 25% say they always use it. What do our respondents think is the main disadvantage of the leads? Well, like we saw before, they think that the programming is too time consuming. It was the winner by far, the 24 responses, and then followed by the price of the leads. But do they think that these advantages outweigh the advantages? No, they think that 65% of respondents think that the advantages are still superior than the disadvantages, as we can see in this graph. And do the patients fare better with these programming strategies, with steering? Most of our respondents think they do, at least a bit better. A bit more than half thought that they fared at least a bit better, and only 5% thought that they fared a bit worse, and no one thought that they fared much worse. And this benefit varies according to indications. At least that's the perspective of our respondents, and they think that PD patients are the indication that benefits the most, followed by essential tremor and dystonia. This is also what we saw in the impression with indications. And then for the other indications, they feel that the benefit is not much. Then finally, we wanted to analyze what the community thinks about the future technologies and the future needs for DBS. And we asked them what were the three technological advancements they thought were most important to have in the future. And we can see here that the winners were closed loop. They were the most voted, followed by sensing and 3 Tesla compatibility, and then remote programming and longer battery life, etc., etc. Interestingly, we can see here that not many respondents wanted more directional contacts, and we will see that ahead. And AI, it's not a very much wanted technology, at least for now. So it's good to see that these the most voted technologies are already on the market, at least with some firms. We also asked, what do you think is the perfect configuration of a directional lead? And we see that most of the respondents think that 4 segmented contacts divided in 3 would be the best configuration. Not many people want more segmented contacts, and also they don't think that a more segmented contact is needed, as you can see here. And only 8 people thought that the current configuration is the best. Then we moved on to make some questions about technology. And the first one was if they think that sensing technology could fasten the adoption of directionality. And most of people think so in some way. A minority doesn't think it will affect it. We also asked to what extent do they believe that sensing technology with reported symptoms could revolutionize the treatment outcomes of DVS patients. 26% think that yes, to a greater extent, sensing will revolutionize this. But most people thought, well, to some extent, related to decreasing stimulation parameters and prolonging generator life, mainly. 7% think will be a placebo effect, and 4% doesn't think it will bring any revolution. And what about the role of artificial intelligence? Most of the respondents think it will be an advantage. Most of respondents think that it will improve long-term outcomes, minimize the side effects, and help identify some trends that can lead us to a more efficacious treatment, or identify some need for adjustment. Then they also think that it might shorten or streamline the initial programming time. And a minority thinks that it will only be useful for not optimally positioned electrodes, or only in the initial stages of programming. Only 9 respondents think that it will not change current practice AI. And finally, we asked if respondents believe that open loop will move on to a closed loop in the most used indications. And 47% think that is very likely, that systems will become closed loop. And 43% of people think only to some extent. Only 6% think that that won't happen at all. And then we were asking what degree of freedom of control we would be comfortable giving the patient and the system. And here we can see that the respondents were a bit reluctant to give full control to an automated system for various reasons, as you can see here. And those were our results. And thank you for your attention.
Thanks, Pedro, for this nice overview of the survey results. I think it's very important to know what's going on the DBS field among our colleagues. We have one question in the Q&A, but we will discuss them afterwards. Now I will introduce you Marie Kruger, already introduced. She's a well-known neurosurgeon and will tell us about the directionality of the DBS leads and give a nice overview of the literature. Please, Marie.
Thank you very much, Linda. Thank you, Pedro, for the nice presentation. So I'm going to share my screen first, and I hope you can see my slides. So the idea that we had was that Pedro starts with the survey, and now I'll try to give an overview on the D-lead literature. And I'm going to refer back to some of the questions and answers we had to see how much the opinion is in line with what the literature is telling us about directional electrodes. So I'll start with an overview on everything, basically, and then I'll go a little bit more into detail in terms of the experience, lead orientation, lead programming, and then one of the future vision questions. So the first topic that I'm going to cover in terms of or looking at the overall experience is with this question in the back of our minds, and the fact that most of the participants actually think that directional electrodes are either a minor or a major advantage. So the overall gut feeling really is that they are better than omnidirectional electrodes. And this is another interesting question and answer. So most people are using the directional electrodes to get away from side effects or to improve clinical outcomes. So let's see what the literature tells us about these aspects. So first of all, I'd like to acknowledge Victor. I can't really pronounce his last name, sorry. He's a PhD student from Denmark, and we know each other through the EANS. And he's helped me a lot putting these, to do this literature review. So he basically did a very thorough review. He got more than 2,000 hits. And after reviewing the abstracts, there were 200 left. And then we went through all these abstracts and cleaned them. And we found 128 relevant papers on directional electrodes. So I think it's important to keep in mind that they came on the market in Europe in 2015, early 16. So we've had them for 6-7 years, a little bit later in the US. So we've got 6-7 years of experience and 128 papers. We can discuss whether that's a lot or that isn't a lot. The majority of publications is on PD or STN, then quite a lot on tremor, very little on dystonia, quite very little on other indications, quite a lot on programming, and a lot on technical aspects, like how do we determine the lead's orientation and when should we determine it. A few reviews and opinions. So I won't go into those, but I'll try to cover all of those. And I'll just try to give a broad overview, really. So I'll start with the PDSTN publication. So there are 36 in total. 18 of them are more theoretical, looking at anatomical correlations and LFPs. There are 12 that are actually comparing directional versus omnidirectional, either settings or old omnidirectional electrodes with new directional electrodes. And there are 6 papers that report on the experience and on programming outcomes, basically. So I won't discuss those now. I'll wait for the tremor papers. And then I'll discuss all these experiences together because it's quite interesting to compare the PD and the VIM programming strategies. So in terms of clinical outcome, there are a few things that are important to consider here. So this is just a table and I'll walk you through it. And I want to go further into detail in these 4 papers. So the early ones, 2014, were just intraoperative studies, just like feasibility studies, or they had very short follow-up times. After that, we had a few studies that had a follow-up time, also very short, 3, maximum 6 months. And in fact, there's only one paper that has a longer follow-up time, which is 12 months. I just think that's important because my personal experience is that we're actually doing quite well in newly implanted patients. You have a lesion effect, and you don't really know whether your electrode is perfectly placed, and it's not really getting challenging before a year is over. So we have to keep that in mind when we look at the literature. The other thing to keep in mind is that the numbers are very, very small. We have sometimes only 8 or 7 patients in these studies. There is one study that has 234. That's the biggest number of all. So I'm going to go a little bit more into detail on this paper. Now, if we look at the outcome, most of the papers were focusing on the therapeutic window. And as you can see with the plus here, that means that the directional electrodes are superior to the omnidirectional electrode when it comes to the therapeutic window. But the other thing that's very important and stands out really is that all the papers that have looked at UPDRS scores, they did not find any superiority for or in favor of the directional electrodes. Now, the question is this because the follow-up times were so small or because there is no superiority. So I think the big question is, do the therapeutic window and all these theoretical benefits at some point translate into clinical benefits? There is one paper which is only a preprint, so don't want to discuss it too much because it's not peer reviewed, but I kept it in because this is actually a study where they didn't look at the UPDRS scores, but they looked at other motor tasks like timed up and go, balance. And here it looked like the directional electrodes were actually performing better, although the follow-up was only 1 month after the implantation. So I'll go into a little bit more of a detail here in these 4 studies. So this is the first ever published study by Polo. They did intraoperative tests, 11 patients, PD, 2 ET patients, STN and VIM, and they basically found that the thresholds for effects and side effects were different when they compared the single contacts to the ring mode. And this one is a study from Dembeck that was published in, I think, 2017. It's quite representative of all the other studies that were published around that time because it had a small number of patients and a short follow-up time, but they all showed the same. And basically that the therapeutic window is larger in the directional electrodes, that they have a higher threshold for side effects, but that the clinical results are actually comparable to the omnidirectional settings or electrodes. So this is the study with the largest number of patients, 234 PD patients and 194 with a 6-month follow-up, 37 centers, 7 countries. It's a prospective double-blind crossover study. All sounds really good. If you go a little bit more into detail, I think there are a few flaws, unfortunately, that make the results a bit questionable, but it's still the only study that has more than 100 patients included. So their primary outcome was the therapeutic window. And what they did was they put all the patients on an omnidirectional mode for 3 months. And then they switched all the patients to a directional mode after these 3 months. So after 6 months, they got the results on the directional modes. Now, apparently the patients and the clinicians were blinded, but they didn't randomize these settings, but let's hope they were really blinded. If you look at the therapeutic window, again, directional electrodes were superior. Don't think that's surprising. That kind of reconfirms everything that we've seen so far. Therapeutic current strength was lower, so also in favor of the directional electrodes. The interesting thing here is if we look at the UPDRS score and we compare the omnidirectional settings to the directional settings, you can see that comparing off versus on stimulation, the actual benefit is pretty much exactly the same. So there's one thing that I don't like about this study, and that's the fact that they did this comparison with medication on. So how much of this is medication, how much of this is stimulation is really difficult to say. And the other thing that I found interesting here was that the baseline before surgery with medication, the patients were actually doing better than after the surgery. And it looks like patients had deteriorated a lot, which is a bit questionable. So I think that's the major disadvantage of this study, that they didn't do it with medication off, which is usually how you would evaluate the amount of stimulation or the improvement of stimulation. So we have to, take the results with, a bit of a question mark. But still, they reconfirmed that the therapeutic window is definitely wider in directional electrodes. The last study I wanted to go into more detail is this one, because they did something slightly different. First of all, they had the longest follow-up, or they looked at the results after 12 months. They compared 52 directional electrodes to 57 omnidirectional electrodes. This was a registry-based comparison. And they did not only look at the UPDRS, well, they did, and it was comparable, but they also looked at the levodopa equivalent daily dose reduction. So the amount of drug reduction that the patients were able to get. And here you can see that the directional electrodes were definitely better. They were able to reduce medication like 13% more than in the omnidirectional group. Now we could argue or discuss whether this is significant and this is enough. And then the quality, one of the quality of life tests was also showed a greater improvement in favor of the directional electrode. So I thought I wanted to mention this study again. It's not a perfect design, but it is one of, I think the only study that I found, which is not only looking at the UPDRS, but at medication reduction, quality of life. So maybe we just don't really see the effects in the UPDRS score, but if we look at other things, we might see them. Just a question that I'm putting out there. So to summarize the literature on STN or PD for directional electrodes, we have very short follow-up times. We have an overall small number of patients, so there's clearly a gap in the literature. And the theoretical benefits are definitely there, but so far we can only see little clinical benefits in the short term. So one thing that we can discuss is, this overall opinion of our experts, and that's actually my gut feeling too, that they are actually better than the omnidirectional electrodes, isn't really represented in the literature. So maybe we just have to wait a little bit longer to get studies that looked at 1-year outcomes or 2-year outcomes, or we have to look at different things and not just purely the UPDRS scores. So again, something I want to put out there to discuss later. Let's have a look at the tremor studies. So tremor and VIM studies, there were 22, 4 that were only or mainly looking at the therapeutic window, 4 that were looking at trying to reduce side effects, 4 that were looking at anatomical correlations, 6, again, experience and programming. So I'll discuss those at the end together with the STN studies, and then 4 case reports, and I won't go into those. So if you look at the time point of publications, again, I think it's quite interesting that there wasn't much at the beginning, and now it just peaked last year. So this is, of course, 2023 isn't over yet, and the literature review was done in April. So we probably will have a lot more by the end of this year. But there wasn't much at the beginning, which is the natural course, but it also shows that we can expect more in the coming years. So just a very brief overview, and I'll just quickly walk you through it. I can make this very short. So if you look at the papers that mainly were focusing on the therapeutic window or the tremor improvement, we have a similar situation as with the STN studies. Very small numbers of patients, and very short follow-up, 6 to 8 weeks. This one was 6 months, but very overall, nothing really beyond a year. This study only had 2 or 3 patients that were actually more than a year or so. Again, therapeutic window clearly in favor of directional electrodes. But again, if you look at the tremor reduction, they're not superior clinically compared to either omnidirectional electrodes or a ring mode. A lot of studies, or 4 studies, were able to show that it's more easy to reduce side effects when you use directional electrodes. This one actually also showed that a short pulse width is superior to directionality. But if you combine directionality and the short pulse width, you can actually get better results than with short pulse width alone. So that was the follow-up study on that. And I'm going to go a little bit more into detail with this study here. This is one of my publications because it's a little bit different, and you can see that it has a plus here. So this was a study where we exchanged electrodes after patients had their electrode for 3 to 8 years. So it's actually still the only study that was looking at a more advanced group of patients. And we actually did find that the directionality had a positive impact on the tremor. And we were also looking at quality of life. So I'll just show you a few results in a second. And then there are quite a few studies on anatomical correlations. So which some of them are really good, nicely showing the correlation of the fiber tracts and how when you steer into the side effect areas, how that has a clinical impact. And I'm going to discuss this study because it's kind of like a follow-up on our first study here, and to demonstrate or give an anatomical explanation why patients can improve if you exchange a standard lead for a directional electrode. So I'll just discuss this study a bit more in detail. This is from my time in Vancouver with Chris Honey and his team. So we had 6 patients with bilateral VIM DBS who had a standard electrode, and they initially had very good tremor control, optimally placed leads. And we did get further tremor control, but only for the expense of side effects. And after 3 to 9 years, the patient's tremor had progressed to such an extent that the tremor improvement wasn't sufficient anymore. But when we tried to crank up the stimulation, they got the side effects. So we decided to exchange these electrodes for directional electrodes, waited for 4 weeks, programmed them on a directional setting, took us up to 16 weeks. And then after 3 months on the best setting, we did quality of life tests, compared them to the quality of life before. And then we did the tremor scores before and compared them to after we had put them on the directional settings. And these were the results. So again, just to remind you, these were advanced patients, not 3 months after surgery, 6 or 3 or 9 years after the first surgery. And we found significant tremor improvement. If you look at the blue bars here that are much lower than the yellow ones, and significant improvements in terms of the quality of life. And we looked at the QUEST, which is the quality of life for tremor, and the VHI, which is the quality of life for voice, because most of them had dysarthria as one of their major side effects. Now, it took us a long time to program these patients, and I'm mentioning this because this will come up later in my talk, and Pedro had mentioned our that most people think that the programming time and the longer programming time is the main disadvantage of these electrodes. So the first patient took us 28 hours to program, but we had put them on most complex multi-level directional bipolar settings, really trying everything. And we did not have any images. So it was a trial and error programming. We had a learning curve here. But still, even 4 hours to program a tremor patient is a long time. We usually get them better quite quicker. So what was the anatomical correlation here? If you look at the amount of stimulation of the fiber tracts, this is the cerebellothalamic tract, which is the DRT basically. You can see that the amount of CBT stimulation was pretty much the same for both electrodes. But now we, with the directional electrodes, and because we wanted to replace the best segment with a directional electrode, we had to push the directional electrodes a bit deeper to have the directional settings on the best level, which was usually the deepest. So in some of them, we had a deeper contact, and we used the deeper contacts. And because we were able to use the directional modes, we were able to steer away from especially the ataxia side effect that you often get when you're very deep. And that allowed us to also stimulate the pallidofugal tract. So as you can see here, the difference was huge for the directional electrodes. So we had an additional 20% of tremor improvement stimulating the pallidofugal tract. Now, you could argue that you can do that with a standard lead if you push it deeper, but from my experience, you need directionality to steer away from the ataxia fibers, basically, to get these effects without side effects. That's all I wanted to say about tremor. Now let's move on to the other indications. And this is going to be very quick because unfortunately, if you want to put it that way, there aren't that many studies. So there's truly a gap in the literature when it comes to other indications. There are only 4 case reports. So the yellow ones are all case reports on dystonia. And 2 studies were using the directionality to steer away from a side effect. Then we found 2 other studies that had put directional electrodes in, but they didn't really use directionality. There were 5 case reports, or 4 case reports, and 1 case series with 3 patients on psychiatric indications, 2 case reports on pain, and 1 on dementia. But no publications on epilepsy and no publications on depression, at least nothing that we found. So I think that kind of, in a way, I was a bit surprised. And maybe it's not surprising, but maybe there are a lot of papers in the works at the moment, but there's clearly a gap in the literature for everything other than STN and tremor. So if we look at this question and answer again, and the question, how many electrodes or how much directionality is actually utilized. So we can see that the later, the more patients are on a directional mode. So let's have a look at the literature if this correlates with what's been published so far. So there are 6 papers that were looking at STN and tremor, and 1 looking at VIM only, 1 looking at STN only, so 7 publications in total. Reasonable numbers. Main targets were the VIM and the STN, very few that used GPI for PD patients. The follow-up times, again, were relatively short, usually around 6 months. There is 1 study that stands out a bit because it was looking at 3 months, 12, 24, and 36 months. So I'm going to go into more detail with this publication. And then this one is quite representative because it was after 6 months. And it had quite a lot of electrodes on a directional mode. So this was this one with 57 PD patients, 105 STN leads, 33 ET patients, and 52 VIM leads. And what we can see, when we look at the PD STN patients, that the therapeutic current strength was in favor of the directional electrodes. Again, therapeutic window in favor of the directional electrodes. Again, they didn't look into UPDRS scores or anything like that. And what you can see is that the majority of patients here, both STN and VIM, was on a directional mode. So 73% of STN patients and 78% of the VIM patients at the 6-month follow-up were on a, sorry, that doesn't quite match, 65 it was, sorry. Well, more. We're on a directional mode than we're on a non-directional mode. Again, this is quite representative of the other studies. And this one was the one with the longest follow-up. And what is interesting is that initially, or at the 3 months follow-up, the gray ones, the light gray ones are the VIM or essential tremor patients. The majority was on a directional mode, but actually the number went down over time. Whereas it was the other way around with the PD patients. Here the numbers went up, especially after 3 years. And this is actually the only study that has a follow-up time of 36 months. So again, I'm wondering whether all these theoretical benefits will actually translate into clinical benefits if we look at 2-year outcomes or 3-year outcomes. The reasons why the directionality was used is quite similar for both leads. Initially, side effects or to get better tremor control. And then at some point, I think people manage the side effects, but only want better tremor control, which is the light gray here. Same for the VIM. So if we take all of this together, there is quite a big variety from VIM directional modes from 38% to 91%, and STN 32% to 84%. VIM electrodes are slightly more put on directional mode than STN ones, and the later, the more are on a directional setting. But no one has actually looked at the correlation with the lead position. Is this, are the patients that are on a directional mode the ones where the electrode isn't perfectly placed, or does that play, is there any correlation between electrode placement and whether we need directionality? Because that was one of the big discussion points at the beginning when they came out. You only you need directionality if you're not a good surgeon and if you can't place the electrodes perfectly. Moving on to lead orientation. So here we ask, how do you determine the lead orientation and when do you determine it? And I'm not going to go over all this again, but I think what is very obvious is that there are a lot of different ways that are being used to determine lead orientation, and that the time point seems to be very unclear from it doesn't matter after first week, after 24 hours to I don't know. So the first question we have to ask ourselves is not how and when, but actually why do we need to know lead orientation? And I think the answer is no. If you only want to do black box clinical programming like we've done all these times. But we've also seen in the survey that if you do use directional electrodes, the programming time increases. And one way of reducing it is to use imaging to help you. And so as soon as you want to use imaging, you need to know the lead orientation. Because if you have an electrode here and you have a side effect, like a capsule side effect, all you have to do is do a few clicks to steer away from it. But of course, you need to know exactly how the lead is oriented. Otherwise, there's no point. And actually, if you're not sure, it'll confuse you more than it'll help you. So there are many ways. An X-ray is unfortunately not accurate enough. If you look at the marker and if you look at the electrode here, it's actually, the marker looks pretty much the same on an X-ray from minus 30 degrees to plus 30 degrees. So this is something to keep in mind if you're using an X-ray. The way to make this system or this method more precise is to use the iron sight method here, which means you're using the lines in between the split contacts. This will only increase your accuracy to 12%, which I think is probably good enough for clinical practice. But the marker or these gaps will still look the same between minus and plus 6 degrees. And you also have to keep in mind that this is in relation to the frame and not to the ACPC line. So if you put the frame on with a bit of an angle, which usually happens, not huge, but that adds another 2 or 3 degrees. So it's not the most reliable method. The rotational fluoroscopy, this was a paper by Peter Reinacher in 2017. I think the first one that was really reliably detecting the lead's orientation. Is much more precise. You can break it down to, I think, 2 or 3 degrees. So if you look here and you look at the marker, it looks the same. But if you continue to rotate it, at some point, you can see the iron sights here. And because you can go back and forth, you can find them when they're at their brightest. And that's when the electrode is truly anterior. The method that most people are using now is the CT method. And the good thing about the CT method is that it's integrated as an algorithm in most of the software that we're using. So the commercially available LeadDBS software, but BrainLab Elements has it for the Boston leads, and SureTune has it for the Medtronic leads. So basically, we only have to press 2 or 3 buttons, and then we get the lead orientation. The disadvantage is that for at least some of the versions, you still have to tell the program whether the lead is oriented with an anterior or a posterior orientation. And from my own experience as a surgeon, I know that sometimes we don't get it right, although we think we do. And then the other disadvantage is there's no way of controlling this, or you just have to trust the CT blindly. Whereas with the rotational fluoroscopy, you can actually see it with your own eyes. The next big question is, when is the orientation stable? And this was the first publication on this topic, which caused a lot of confusion, I think, because this study here from Cologne showed that despite the intention to implant the electrodes with a 0-degree orientation, most electrodes were not in that position. And now the question was, were they not implanted with 0 degrees, or did they rotate after the implantation? And to make a long story short, there have been 5 studies now on this topic. And this one was an animal study where the team in Freiburg put a lot of rotation and twist on the leads. And they actually did see quite a lot of delayed rotation. But in the clinical studies, and 2 of them are from my group, we did not see any delayed orientation. At least no one saw any after 24 hours. But it does depend on the surgical technique, the amount of twist you give, the locking mechanism. And I think the most twist we give when we actually lock the leads in, because you often have to, you have to bend them a bit and you do twist them. So it's really difficult to get 0 degrees. It's almost impossible. And plus minus 30 is what we usually see in our post-op scans. This is a study that's in print, but it's just quickly to show you again what's been done, and that there are no clinical studies on Medtronic electrodes yet. There's one by Medtronic, but that's an animal study. And most did not use a burr hole cover. They use bone cement or clamps or titanium plates. So I think it also very much depends on the mechanism that you use. So ultimately, I think every center will have to find out for themselves. But if you do it, accurately, there shouldn't be any rotation after 24 hours. I think, so if you look at the amount of literature that's been published on this topic, it's crazy. I mean, there are 20 studies, more than 20 studies dealing with these whole lead orientation aspects. And the amount of confusion there still is in the community, I think, is interesting, because you should think that, with the help of the literature, we have figured it out. But it's maybe sometimes even more confusing to have too many publications on one topic. Looking at lead programming, and I'll come back to this question and answer, the programming time, which is too time consuming. So one, and quite severely so. One advantage, or one, not advantage, one answer is to use directionality. And if we look at the number of literature or the number of papers, there are 19 that are dealing with this whole question of programming electrodes. And 16 are looking at image-guided programming and how to use algorithms. So a lot on programming. And if I remember correctly, only 17% were actually using images. So there's a big discrepancy between, who's actually using images and how much is published on this topic. And then when we look at, there are 2 papers that are actually asking the question, when and how should you do the programming, and then 1 case report. And it's not surprising, I think, that most of these studies were published in 2021 onwards. So I just picked out 2. This is the most sophisticated one, I think, or at least I found. And here the authors are feeding a software the images, the lead position. Then they also give it the clinical outcomes for each contact. And then they're trying to develop an algorithm that can then predict the best contact for future patients. So basically using imaging, using clinical outcomes and computer models to let basically the algorithm do the job to cut down programming time and hopefully try to improve the outcome as well. This is really amazing work, I think. I think this is the future, but we're still quite far away from it, at least most of the centers, including us. We're using imaging, but we're not feeding algorithms or programs with it yet. The other paper that I really liked is this one from Bern, because they looked at it from a different angle, and they were actually asking the question, do we need to do this directional testing in everyone? And their conclusion was actually that you don't have to do that. If you have a therapeutic window of less than 2 milliamps, then yes, it's worth going or doing contact by contact. But if on your directional, if you're on your monopolar review, you have a therapeutic window of the single 4 segments above 2 milliamps, you don't really have to go into each one of the 6 directional contacts. So just do what you always did, and the outcome will be pretty much the same. So this is the other extreme, saying, you know, you don't have to use directionality unless you run into a problem. I spoke to Paul Kruck, who's one of the co-authors, and he says, you know, we're actually only doing the directional testing in probably around 20% of patients now, because you don't really need it that much. Okay, last slide, future vision. I just wanted to pick out this question because I think it's very interesting, because this was the wish list of our authors. What do we want? A lot of these things we already have, I think. We have sensing in the Medtronic electrode. We have 3T compatibility also in the Medtronic electrode, but to be honest, we do 3T post-op scans with our Boston leads as well. You just have to do a few tests before. Remote programming we have from the Abbott leads, and automatic orientation detection. I think that's integrated in the softwares that the companies also provide. There we're quite close to closed loop, or we're getting there with the sensing abilities now. Longer battery life. I think now that Medtronic is bringing out a rechargeable battery for the sensing, I think that's a step in the right direction. I don't think that we can expect PCs to last longer with all the extra technology that we have. So smaller IPGs, again, I think Medtronic's bringing out a really tiny battery. So I think it's what we would like is the best of everything of the 3 companies combined into one. And I'm sure they are all working on that. But a lot of these things we have already. And as Pedro mentioned, I was very surprised too to see that we don't really want more directional contacts, mainly probably because it is more time consuming. And if you have too many options, that can sometimes be a disadvantage. And that's the end of my talk. And I just wanted to invite every one of you to our Queen Square Functional Neurosurgery Stimulation course, which will be in November with the whole Queen Square team. And we will do DBS surgery, simulation, radiofrequency ablation, programming, directional programming, planning, and everything. So if you're interested, have a look at the website and you can sign up for it. And now that's it. And I will stop sharing my screen and give back to Linda.
Thank you, Mary, for this nice and complete overview of the literature. I think directional lead can be a game changer. You already mentioned it. There are 2 questions raised in the Q&A, and we have a few minutes left, so I will read out the question from an anonymous attendee. Were there any specific considerations on pediatric patients with dystonia? Pedro, can you comment on that, please?
No, we didn't look into pediatrics separately. So we just made the questions generally. So we don't have that information now.
And do you think there is a difference in pediatric patients to use directional leads?
I don't know, probably not really that much, because structures are small, but not that much. And maybe the same benefit will come out from as for an adult, I would say. I don't know, Marie, what do you think?
Yeah, pretty much the same. So we didn't look into it. There's nothing in the literature obviously. And we always use directionality, but not only in our pediatric patients. We always programmed the GPI, or not always, but mostly try to program them image-based trying to steer into the anatomically best or location, because you don't see the effect immediately. So you kind of hope for the best if you put them on what you think is the best anatomically, but that we didn't differentiate between pediatric patients or adult patients. So I agree with Pedro, probably not a big difference.
Okay, thank you. And another question raised by Albert Colon. How about combining open and closed loop in the same patient, like open for the neuromodulation, but closed for the intervention? You've done that before, or do you want, that's a possibility, Marie?
Yeah, would be nice. To be honest, I have little experience with the closed loop and the sensing and all that so far. That's probably the area which has the most potential, but I think it'll still take quite a while for us to get really ahead in the field. If you look at what's been published, you know, there are a few interesting aspects, but we're surely quite far away from any breakthroughs yet. That's my gut feeling or my experience. I don't know, Pedro, what do you think?
Well, there, at least from the survey point of view, there are many people that wish that, right? That the two options are available, and probably there will be. I think there will always be a manual mode, let's say. But yeah, about like open for neuromodulation, closed for intervention. What exactly do you mean? It's when we are programming, we can just do whatever we want and then close it. That's what you mean, and it will run on its own.
I think so. I think because the person who raised the question has much experience about epilepsy patients. So I think that's the main reason about his question.
Yeah, I think the only way for this to open is to be an option, right? And we just choose wherever we find more comfortable, and probably it will have some patients will go on a closed loop and it will work perfectly for them, and some others will need some tweaking. But I think this technology would need to be fed by all the sensing information that Medtronic is collecting now. So the more, it's like an AI, right? So the more you feed it, the more well trained it will be. And so I think we just have to wait to see.
Okay, thanks. Marie, I have a question. What do you think the industry or suppliers should focus on regarding new technologies? Do you think the automatic post-op planning or programming, you mentioned it a little bit, but what do you think the suppliers should put their money on?
Well, I'm always a bit torn between making it more complex and having it, you know, going back to the simple model that we used to have, because that seemed to work really well too. But making it more affordable for more patients rather than making it more expensive and more complex to help these, you know, maybe 10% of patients that might benefit from all these techniques. But if I could wish my perfect electrode, I would go for basically the best of the three worlds. So sensing from Medtronic, remote programming from Abbott, and I really like the post-op imaging with the collaboration with BrainLab that Boston has. So image guided programming on the Boston level, that would be my perfect electrode. And probably I wouldn't mind having the bottom and the top contact as a directional lead as well, just because it would, sometimes you miss it, and you do have to, sometimes we do adjust the way we implant the electrode, and then you realize I should have just done it differently because now the contact isn't where it should be, the directional contact. But then I think we really need to focus on post-op, making things easier, which is, I think, happening. It's all happening. It'll take time. But for me, the most pressing thing at the moment is remote programming, because I think that's very important, because a lot of people come from further away. And I think that's a good step in the right direction, rather than just making the technical aspects more demanding.
And Pedro, what's your opinion about?
Yeah, I totally agree with Mari. I think it's the things I would wish the most for too. And remote programming, yeah, it's very useful. Here in my institution, we don't use Abbott. And indeed, we have this problem because patients come over a lot of kilometers just to be programmed for like 1 hour. And so, yeah, but I totally agree with those technologies.
What's your opinion, Linda?
I think remote programming is a big advantage, but I really like to have one complete setup of all the information for the patient in one single device, like the contacts, the electrodes, the steering electrodes, the position, the MRI scan on a real tiny tablet or display, which I can show to the patient as well. And not all the different planning stations, on all different devices. I think that it should, for me, be of big advantage. No more steering contacts on one electrode. I like the steering, but I don't need that much electrodes on one, contacts on one electrode. So a complete setup for one patient. Probably remote is the best. Yeah. And of course, wireless yes. Devices, but that's a completely other different story. We should have arranged a webinar on. So there are no further questions in the Q&A, and we were a little bit over time. So if there are no further questions to these experts, I will close this session for today, and I will thank the speakers and for you joining, and hope to see you on the next webinar or on the next ENA Congress in Barcelona, and have a nice day. Hope to see you soon, and stay safe.
Have a nice evening, everyone.
Thank you all.
Thanks for joining.
Thank you.
Bye-bye.
Bye.